Thank you. Well, I'm honored and humbled to be here today speaking with you. I never would have imagined that I would be talking about a subject like this in Norway. I kind of stayed in the closet for more than a few years since I moved here from New York about 6 years ago. But nonetheless, here we are. And I'm still primed, I think beautifully so, from our previous speakers' speaking points on phenomenology, epistemology, and philosophy and theory of mind in general. So excuse if I come at this topic from the head and into the body rather than the other way. But I want to talk about psychedelics a bit, of course, and I want to talk about pain, something we all have a relationship to, with, and about and at certain points of our lives. Some of us feel it every day. Some of us feel it early on or later on. And I want to talk about it in light of a biopsychospiritual model, something that is not quite often spoken about, but now I think has the leverage and momentum to do so. So just to give you a format, a battle plan, as we say, of this talk today, very brief in the time that we have, I want to start with my journey because I think meaningful work such as this that we all share together in this community starts with a personal narrative, and that narrative becomes a social narrative. I want to then discuss chronic pain in general and psychological distress, a quite common comorbid ailment of those suffering from long-term pain. Move into psychedelics themselves for pain and the application as a tool, and go further into our next steps in this field at large. So first, I'll start with myself, which is kind of ironic because we're talking about ego dissolution, but I am American, so it's hard to do so. But they always have to start with themselves, right? So I started my journey a few years ago, more than a few now, studying medicine, mainstream medicine and Western medicine. And at that time, I was fascinated by Ayurvedic medicine. I was invited to the Center of Healthy Minds, worked with Richard Davidson to study long-term Tibetan meditators. We're doing some imaging work on these meditators, flew them in from the Tibetan plateau out to Madison, Wisconsin, and stuck them in imaging facilities, and looked at how empathy-based practices like mindfulness, like meditation, some of these techniques and tools you probably have heard of previously, imbue certain neurophysiological, neurobiological, neurochemical effects within the brain and our viscera below the neck. But I wasn't really satisfied by the, I guess you can call the objective stance of research. I wanted to get in the field a bit more. So I wanted to work in the Bronx in Manhattan to start dealing with the ill and working hands-on with cancer patients. Pain is known within the body. It's embodied by those with cancer quite often. And I started leading contemplative psychotherapy, contemplative therapy workshops for cancer patients in a workshop group setting. Space is charged. The clinical encounter is bi-directional. It's not unidirectional. It's not top-down. It's not bottom-up. The clinical caregiver, physician, healthcare practitioner knows something in their mind quite well. The patient knows something in their body, the lived experience. So I wanted to explore that a bit in that element, in that sector, and so I engaged the cancer population there and worked for quite a few years at Albert Einstein Medical School in that perspective. And I was invited from that work to the Spirituality Mind-Body Institute. It's a wonderful institute started a few years ago by Lisa Miller. And there I was studying under certain leaders in shamanic practices and shamanic ritual practices from the Amazon basin. I studied with Ruth Rosenbaum, who is a specialist in near-death experiences and the hallucinogenic psychoactive properties of dying. And so that kind of contextualized the field a bit for me. Now, again, teasing more and more this psychoactive or psycho-affective property of otherworldly experiences. And that brought me into meditation, vagus stimulation, and presently now psychedelics here today. So let's talk about chronic pain. I want to talk about first, from a bird's eye view, and then honing in. It's a global burden, so it affects the individual, also affects the community, socioeconomically, sociologically. These are just rough schematic percentages taken from various populations, whether it's pooled data or segmented. But just know that it is a global burden. About one out of every 10 people suffer from long-term pain. And again, long-term pain doesn't mean that you're going to have it forever. Chronic pain doesn't necessarily last forever. It just means that you've had pain that lasts longer than at least 3 months, okay, or more. And it seems to affect women more than men. Why that's the case, we have yet to know. There are genetic factors in this. There are environmental factors. There are sociological factors. There's epigenetics involved. There are cognitive, emotional, affective, psychological, visceral, physiological. Pain is a quite exciting field. It's not just cardiology, excuse if there are any cardiologists in the room here, but it involves the system. It commands the system, it dominates the system, and it challenges the system. And that's why when we want to talk about what we can deliver to those suffering and pain, thinking innovatively, effectively, non-invasively, efficiently, that's why psychedelics seem to be a promising path ahead. So here in Norway, in the Nordic region, it's quite an issue. It's actually arguably, I would say, but I'm biased, but I would say that a lot of National Institute health data so far has seen this to be the #1 cause of emotional disability and professional sick leave that is befalling our population here in Norway. It affects Sweden as well as Denmark. And why is that the case? Again, it might be population, or it might be reporting prevalences. It might be those that are stricken with pain are given more care at a higher rate. And there are different theories and propositions as to why that might be the case, but it just seems to be so nonetheless. So what does this leave us here? We know that in the field of pain, we're at pretty much between a rock and a hard place. There are a lot of treatments out there. And the efficacy of these treatments is not really to where we want them to be, where we need them to be. Patients have expectations, physicians, clinical researchers have expectations. Patients are trying to appreciate those expectations, and when you live a life by expectation, it's quite hard to appreciate anything, especially when you're suffering. But when you can change your expectation to appreciation, everything kind of seems to sometimes fall into place. And it's really what we're attending to. What are we after? What does a patient want? What does the doctor want? What are our goals? Do we want to rid ourselves of pain? Well, sometimes pain is an informant. Pain sometimes brings patients into a community, whether of a religiosity community. It brings them deeper in connection with themselves, with their past, with a physician. So quite ironically, you can see that the hardships that sometimes govern our lives in one point or another through our human development are the very messengers or things or arbiters upon which we can ride to a state of greater meaning. Okay, so it might not necessarily be that we are looking at psychedelics to eradicate pain, but more so maybe gain a new insight into how we relate to it. Okay, because the body is designed to take it. As far as I'm concerned, it's designed, it's a vehicle of flexibility, psychophysiological flexibility. So let's look at this together here. And when I started my journey, not only personally, but professionally, I started to see a natural momentum of not only the literature and the publications that others were engaging with in the field, but my own. In the early 2000s, around 2000, 2010, that first decade, you see this biopsychosocial model of pain and pain management and treatment that is practiced mainstream in the hospitals and clinical institutes throughout the world, slowly transitioning into the biopsychospiritual. One can see this as maybe a pseudo-Kuhnian paradigm shift, but I think psychedelics need a home. You know, the success of an organism is not independent of its environment. It needs habituation. It needs to be housed mutually with its surroundings. And the surroundings of medicine, just like an organism in an ecosystem, is quite similar if one were to push the analogy as far as it can go. And that's why psychedelics, I think, need this biopsychospiritual class to sit in attendance, because, again, I don't think it's about also taking out the social element of pain, even though it's biopsychospiritual, yet one can argue that the social practice is a spiritual endeavor. It involves many of the certain overlapping regions neurologically with the brain, and we can discuss that later in this talk. But basically it's saying that there's meaning, purpose, and identity that is involved with the illness and well-being journey and the healing journey of that. And we're trying to ingrain that within the medical system, within the community, and we're just at the beginning of this. And we can preserve this physiological element, this objective, empirical, data-driven science, but also combine it with something a bit grander that we're just encountering with today. Nonetheless, when we speak upon the empirical science of the field, we are attending to something which, when we speak about what is the mechanism of action, what is the catalyst, what is the thing that actually delivers the treatment when we talk about psychedelics, especially if we're talking about psychedelics in regards to pain and suffering. And there's some agonists that are going to be spoken about today, and I don't want to commandeer anyone else's following talks on these subjects, but nonetheless, just to touch upon them in the field of pain. Receptors, agonists, one of the things that sparks my interest is functional connectivity. So you'll hear that term a lot today. We talk about connectivity in the brain. We talk about that phenomenon we call binding in long-term meditators. Tibetan meditators exhibit this phenomenon quite nicely when you run live scans on their brain, and regions of their brain that shouldn't be talking are starting to talk. Whether that's a good thing or a bad thing is another, I guess we can ask the philosopher in the room. But nonetheless, you see this coupling and binding with regions, a conversation that is happening under these kinds of mystical-based, psychedelic-based practices. And I think that might be very important for patients with pain due to the fact that when the brain transitions from acute to chronic, we do see a neurobiological shift happening, actually. This is quite clear in a lot of the neuroimaging studies we've done to date. And there is a centralization of pain, but more so there's I guess what one can call a coupling with certain areas that shouldn't be coupled, and a disassociation from areas that shouldn't be dissociated with. We see that the brain, there are certain regions over-coupled, and basically you can call it a bad marriage with certain regions that have to do with, let's say, emotion or emotion regulation, and that those areas are left behind the scenes. Again, the body wants to regulate itself. And so when we look at chronic pain, we're seeing a model, a psychophysiological model that is very rigid and it doesn't want to move. So when we're throwing treatments at it, it's all about, okay, do we attack that rigidity, or do we try to go from underneath or overneath or around and try to imbue a skill set of flexibility? And maybe we can use consciousness as a means of imbuing that flexibility with psychedelics. So that's about connectivity and kind of breaking down the rigidity that we see in chronic pain patients neurologically. But we can't forget that that story or that data has, well, I beat myself there, but it has a story. That data has a story. It's qualitative, not just quantitative. And so what I mean by that is that my work in narrative medicine really teaches physicians, doctors, and clinical researchers how to understand the tool of the personal narrative, that the stories we tell ourselves every day are pretty much the lives we live. I know many of us think we are what we eat, but I always like to say we are what we attend to. And you could say, well, that's your reticular activating system, and you're searching for goal-oriented behavior and task switching. Yes, that's true, but there's a story behind that, and there's a meaning behind that. So psychedelics, for me, when it comes to pain, is all about how can we recognize that story of hurt, because there's damage been done. There's a trauma that needs to be heard, recognized, felt, addressed, not changed, not turned into something better, not turned into something worse. It is what it is, how it is, and why it is. And if we can address that, that's healing in and of itself. So then psychedelics can come in as, yes, I do like this metaphor as a tool. They are tools. I don't think it's the answer, if I may say that early in this conference, but it is a answer. It is a answer, I think, for these patients. So how can we work with the narrative of a patient after administering such a drug and trying to carve out a new meaning, a new reflection and perception of a pain that they have felt in their life? Matter over mind, mind over matter. Again, we're talking about a restoration, a nurturing, and in our next talk, I believe we're going to talk about some anti-inflammatory implications in MDMA and psilocybin, and those are my personal favorites when entering into the field of pain. And of course, there's others, and ketamine has been quite promising as well. But inflammation is a big topic today, and again, the body is in a reactive position, and when we're thinking about psychedelics, for me, I always think about, okay, what is the goal, and how can we imbue flexibility rather than rigidity? There is a tendency for doctors and physicians and my colleagues, including myself, to have a very militant perspective to care, that we attack disease, we eradicate, and I think psychedelics may offer medicine and the school of medicine and the training involved to create good doctors and to create good healthcare professionals with a more flexible, nurturing, functional approach. So future steps here are quite broad and exciting, I would say. So we know that chronic pain has a significant impact upon a patient's sense of meaning, their sense of purpose, and that becomes the purpose of themselves and the purpose of the other, their identity. So we talk about ego dissolution, but the ego is very important. It shouldn't necessarily be eradicated, but reacquainted with, right? So how can we step aside from ego and then step into ego again? And that's quite important when it comes to pain and the transcendent connection to nature. And I put a big N there because, you know, when we talk about spirituality, whether psychedelics have anything to do with spirituality, and that's an argument to be had, right? But I think it has something to say about spirituality. Is it our own nature we're connecting to? Is it the nature of Mother Nature? Is it the nature of our transcendent experience? And that's one that we're going to, I think, explore as technology and imaging gets better. I think we're able to have a procedure to address such things and question them and arrive at some value. And again, we see, again, going back to the empirical science of it, that psychospirituality does have a role. And it's not just about a fatalistic acceptance or whether it's being used for near-death or end-of-life care, but it can be a coping strategy, a skill set that you can imbue neurobehaviorally within the body. Again, the body wants to learn. I mean, the organism is here, it's here. We didn't ask to be here, but we happen to be so. And pain is that inevitable reminder of sometimes who we are, what we're about, but we can find, ironically, sometimes the greatest meaning in life through pain, through hardship. And one size does not fit all. We're going to talk about dosages a lot, and when it comes to pain, microdosing, I think for treatment's sake, probably may not be the way to go. That high dosages are somewhat more promising, whether it's 3 or 4 administrative doses separated by the 2 or 3 week time window. But I personally think that, again, we need to think about the side effects. This is a vulnerable population many times. The body is sensitized, reactive. And so we can't, again, when we talk about throwing something at the body and seeing a reaction come back to us that is beneficial, not only as a healthcare provider, but most importantly, for the user, for the patient, we have to be mindful of that as well. And again, what are the targets? We must think about what is the goal here? What are we after? What does the patient want? What does the person want? And the most important thing is what creates a patient? What takes a person and what evolves them into that mindset? And I think psychedelics can help us understand that evolution within ourselves and with each other in the face of pain. There's spirituality here, there are mystical type experiences here, and there's a community worth exploring. And so thank you again for your time, and I really wish everyone the best moving forward in this quite exciting period in our research, science, and community. Thank you.